I just wanted to touch base a little bit on some treatment side effects. You guys have heard a lot today because the doctors that have talked before me have gone over these very well. But I just wanted to go over a few of them with you and just a few other things from the nursing point of view of what you can do and what you need to do to make yourself successful during treatment. So I think it's really good to understand why these side effects occur, and in order to do that you have to understand what these drugs are doing. And so it was discussed earlier that chemotherapy is cytotoxic, and what it's meant to do is to destroy rapidly dividing cells throughout the body. It cannot differentiate between cancer cells and healthy cells. And we have a lot of rapidly or quickly dividing cells throughout our body, but the ones that we see most are things like blood cells. So it can make you anemic, which leads to fatigue, probably one of the biggest side effects that people get when they're on chemotherapy and long term. Neutropenia, which is our infection fighter, so it can lead to that. And thrombocytopenia, which is bleeding. We also have rapidly dividing cells in our digestive tract, and this is why we see things like mouth sores or mucositis, dry mouth, nausea, diarrhea. We have nerve cells that are impacted, and this is neuropathy, and also hair follicles are rapidly dividing as well. This is why a lot of people lose their hair when they're on chemotherapy. The platinum-based chemotherapies also come with some of their own subsets. We can see hearing loss as well as ringing in the ears. It's very important to let your physicians know if you have any of those because they can be long-term if you just keep letting it go on. It can get worse. We also see nephrotoxicity, so renal failure, acute renal failure can happen, and a lot of patients complain of like a metallic taste. Alimta can cause radiation recall and rash. And you're given folic acid and B12 to help lessen some of the very harmful side effects with the Alimta, so it's very important to stay on that regimen. What we know about chemotherapy is that the side effects are often predictable and they're cumulative. So what we hear most from patients is that they usually happen around 24 to 48 hours after the infusion. They can last anywhere from 3 to 5 days. Your nadir, which is the lowest point where your blood counts are at, that usually happens somewhere between day 14 and 21. That's when you're most susceptible to infection. That's when you really want to watch that you're hand washing, you're doing good hygiene and things such as that. Doses of chemotherapy are usually based on what's called body surface area or your creatinine clearance. And these can be modified somewhat for better tolerability. So if somebody's having trouble with one of the platinum-based chemotherapies, a lot of times we can modify those for you to make them so that you do better, you don't have as many side effects. With chemotherapy, most side effects will subside once the chemotherapy ends. Now there are some that are long-term, so neuropathy can be one that's long-term. Very important to tell your oncologist if you're having that. As well as, like I said, the hearing loss and the ringing in the ears. We have really come and made great strides for minimizing the side effects of chemotherapy, especially things like nausea. We have such great medications on board, so please keep your care team informed because they can help you through those. Don't feel like you have to power through them. It's not what we want you to do. We want you to ask for help. We want to help you so that we can get you through all those treatments as best as what we can. So we have the immunotherapy now, which is very exciting. And I believe it was Dr. Kindler who said, many people think that with immunotherapy you don't have as many side effects. That's not really true. It's just a different set of side effects. To understand these, you need to understand that what the immunotherapy is actually doing is that it's allowing your immune system to recognize these tumor cells and attack these tumor cells. So if you think of a brake pedal, your immune system normally is in checks and balances and has a brake pedal to it. So if you get an infection, it comes at full height, it gets rid of that infection, and then it goes back into a dormant state. When you're on immunotherapy, that doesn't happen. It keeps you heightened all of the time. And so what happens is that immune system then starts to attack healthy cells as well. And it can really cause inflammation anywhere within the body. And when I used to teach immunotherapy, what we used to always say is that these are the itises and the isms. And it's kind of an easy way to remember what can happen while you're on these. So colitis is one of the big ones. Colitis can be abdominal pain, diarrhea, mucus, blood. Hepatitis, the endocrinopathies, so hyper and hypothyroidism, diabetes, and something that's called hypophysitis, which most people have never heard of, but this is an inflammation of your pituitary gland. It can actually present like brain mets. So many people who were on the lung cancer forefront of the Opdivo and the Keytruda, we initially would think that it was brain metastasis because they would come in with confusion and headache and all of the classic symptoms of that, but it's actually an inflammation of the pituitary gland. Pneumonitis is really large, so this is inflammation in the lungs, definitely something that needs to be caught and treated right away. Muscle and joint pain, I get a lot of this from patients, so definitely if you're having those arthralgias, you need to let your care team know. And pruritus or rash. Sometimes rash can itch, sometimes it doesn't. This is one of the ones that can wax and wane, so it's really good to take notice. Do you get it right after the infusion? Do you have it during the infusion? Does it come 2 weeks after the infusion? Does it get worse with each infusion that you have? Immunotherapy side effects are really different from chemotherapy because they're very unpredictable. They can occur at any time throughout treatment, as well as once treatment ceases. So the slides that Dr. Kindler was showing you, where we have seen where people who are even a year out from immunotherapy are still responding to it, that's amazing. But you're also still susceptible to getting those side effects at that year out as well. So we have seen people that have shown up with a hyperactive or a hypoactive thyroid or pneumonitis, and it didn't occur to them that it could be the immunotherapy because they haven't had it for so long, but it can be. Immunotherapy is given often with fixed doses. There's little flexibility in the dosing and the treatment schedule. The side effects of immunotherapy are graded. Chemotherapy are graded as well. Immunotherapy, it's just a little bit more strict to know these grades because they dictate how you can move on from these side effects. So it's graded from a 1 to 5 based upon severity of the adverse event. The earlier the event is reported, the more appropriately we can treat it, and the better the outcomes. So when you get to a grade 2 or a grade 3, we know that that warrants intervention. We want to intervene as soon as possible. When you get to a grade 3 and at a grade 4, it's recommended to permanently discontinue the immunotherapy. We don't really want you to get there. We want to keep you so that at a grade 2, if we have to withhold immunotherapy for a month or 2 and get somebody on steroids so that we can bring that inflammation down and get you restarted on the immunotherapy, that's best case scenario. So very, very important to, I tell people to keep a journal, tell your oncology team right away if any strange symptoms occur, even if it seems very minor to you. It could be very big in a short period of time. One of the really great things about Bristol Myers Squibb, who makes Opdivo and Yervoy, is that on their website they have a checklist, and your oncologist may have these as well. And it tells you to check off what you're feeling. Has anything changed from one treatment to another? Are you noticing something different? Another really, really big thing to know is that they also have wallet cards, and this is huge. And it was really big when these drugs first came out, because when patients show up at a ER with some sort of a side effect, and they tell the person they're on chemotherapy, because who can remember when you're in a situation where you're in an ER and it's acute and you're scared what you're really taking. But for chemotherapy, we don't treat the side effects the same. So it's really important to carry that wallet card or something on you that says what you're really getting, so that they know that they actually need to treat that appropriately. Hydration will do nothing for somebody that's on immunotherapy that has colitis or diarrhea, because you're not treating that underlying problem, you're just putting a Band-Aid on it. So very important, and their website is wonderful. It gives a lot of supplemental patient education materials, as well as materials to bring along with you if ever anything should happen. And then just briefly on the targeted therapies, so Avastin is something that we have seen that's been used in this space. Again, a lot of our research is looking at targeted therapies right now. The side effects with these targeted therapies are usually related to what that specific target is for that drug. So with Avastin, it's VEGF. We talked about this earlier, but it is blocking the growth of new blood cells, so new blood vessel cells. So it's cutting that blood supply off to that tumor. So with that, we see things like nose, gum, you can get rectal bleeding, high blood pressure is really big, stroke, pulmonary embolism, DVTs, and decreased wound healing. So most people who have had like a DVT or a PE in the past are not even eligible for to go on to Avastin. And somebody who has had surgery recently, they would withhold the Avastin for a while, and then they may start it down the line with the chemotherapy, or it would be a drug that they would stop so long before you were going to have surgery. So those are all the things that we're looking for. I hope that helps you guys a little bit. I want to introduce you to Dr. Monica Malec. She is from the University of Chicago. She is one of the palliative care doctors there, and she's going to talk a little bit about that with you guys.
Hi, good morning. Thank you everyone for coming out today. Thank you, Shannon, and thank you to the Mesothelioma Applied Research Foundation for the invitation to come here and talk to you all today. I'm going to be talking to you about the role of palliative care in cancer care, including mesothelioma. A little bit about me. I'm actually part of Dr. Kindler's mesothelioma team at the University of Chicago. So I am in the clinic with them. I see patients alongside them. I go to the tumor boards. I hear about the patients and how they're doing, and what kind of other symptoms they might be experiencing. So we work together as a team. So palliative care is specialized medical care for people who have a serious illness, like cancer. This type of care is focused on providing relief from the symptoms and stresses of serious illness. And the goal is to improve quality of life for both the patient and the family. We really acknowledge that a diagnosis of a serious illness upends your life. Early incorporation of palliative care into cancer care is recommended by an increasing number of professional organizations, including the American Society for Clinical Oncology, or ASCO, the American College of Surgeons Commission on Cancer, the National Comprehensive Cancer Network, and the National Academies of Science, Engineering, and Medicine, formerly the Institute of Medicine. Palliative care is appropriate for you if you're experiencing pain or other symptoms and stresses from your diagnosis, from your cancer, from the disease itself, or from the treatment. And palliative care can be provided at any point during an illness alongside your curative treatments. So you can see that in an ideal situation, you are starting from, the moment that you have any symptoms or stress and continuing on through the course of your treatment from diagnosis through survivorship. The line, I can honestly say, is not usually that smooth. There's frequently ups and downs, and I think if you've been through treatment, you've experienced that. Sometimes we're more involved and see patients more frequently, and sometimes we back off and we haven't seen people in, months and months because everything is going really well and they don't need too much from us. So it's just a high in the hallway at that point. So let me see. Sorry. So as I said, we work together with your other doctors as an extra layer of support for you. And the team provides expert pain and symptom management and additional time for communicating about your goals, and both personal goals and illness goals and treatment options, to give you just more time to talk through how a different treatment might fit into your life and if it makes sense for you. As well as helping you navigate the medical system and ensuring that you have the kind of support that you need when you need it. What you can expect during a palliative care consult. So typically we start with the reason for the consultation, your understanding of your illness and the goals of the treatment and what you might expect from the treatment, and clarify the role of palliative care as part of your medical team and how we'll be communicating with your oncology team. And then review of the symptoms that are affecting your quality of life. And this can include pain, fatigue, shortness of breath, nausea, poor appetite, difficulty sleeping, many of which are very common in mesothelioma. I starred the ones that are most common in pleural mesothelioma. Often nausea, poor appetite, abdominal bloating are more common with peritoneal disease. But we have multiple means of managing these symptoms. And so it's important to share if initial lines of treatment are not working for you. And typically your oncology team will start treatment for symptoms and side effects. And often palliative medicine starts getting involved if those initial treatments aren't working the way we want them to. The goal is really to understand how this illness is affecting your day-to-day life and help you continue to live your day-to-day life and ensure that you have the kinds of supports and symptom management that you need to live as well as you can in the face of a serious illness and as you're going through the treatment. We assess your sources of support and coping and encourage you to partake of those and ensure that you're not withdrawing from all your supports and coping supports so that you have them in place. So we don't want symptoms to be in the way of your ability to get out with your friends and do the things that help you feel better. And then provide a plan of care, which may include medications, referrals to other providers, including nutrition or physical therapy, sometimes our interventional pain services, and we coordinate with the oncology team. But again, the goal is to help you live well in your day-to-day life as you're going through your cancer treatment. Palliative care has many proven benefits. There's a growing body of literature of the benefits of palliative care, including improved symptom management, improved ability to tolerate treatments. It reduces caregiver stress and anxiety, improved quality of life, and it may prolong life. There are several studies that show a significant prolongation of life with palliative care implemented earlier in the course of care. Palliative care and hospice share a philosophy of care, but are not the same thing. Palliative care and hospice services both acknowledge the many stresses of serious illness and coordinate the support of an interdisciplinary team to promote the best possible quality of life. Often, the initial visit with me, people are scared. They're concerned that what is my doctor trying to tell me? And typically we're trying to say, we're here to help you with this symptom that you've been experiencing. But that's usually the first part of the conversation. Hospice services provide palliative care in the final months of life. So if we think about palliative care as a focus on quality of life and symptom management and support throughout the course of your illness, hospice is this focus in the final months of your life. And hospice services are the gold standard model for quality, compassionate care in the final months of life. Hospice services are a wide range of services that surround the patient and family and support them during this time. This is most appropriate at a point in time where the decision has been made to shift the goals of care towards comfort and support, when further cancer-directed therapy is no longer desired or possible. And most of these services are done in the home. They come to you. So I am pleased to share this video about palliative care with you. This is something that was created by our regional therapies team of surgical oncology with Dr. Taraga. I don't know if Dr. Taraga is still here. Dr. Taraga's team made this video, and you are the first to see it outside of us. So this is a short patient education video about palliative care.
Palliative care is medical care that deals with symptom management and better quality of life for people with serious illnesses like cancer. People can see palliative care providers at any time during their treatments, along with their other medical teams, to get support for issues including pain, nausea, appetite, problems sleeping, and they can help you make a plan for who would make medical decisions for you should you not be able to, which is called advanced care plan. Palliative care specialists can also be part of the conversation you have with your medical teams. Your palliative care provider can help as you and your loved ones are trying to understand what your treatment options are and which treatment makes sense for you, your values, and your goals. Palliative care is not the same thing as hospice care. Hospice care is end-of-life care, while palliative care is medicine that helps keep you and your goals at the center of your treatment plan. Palliative care doctors and teams provide an extra layer of support for patients and families as they face the challenges of living with a serious illness.
So I think that very well summarized most of the major points that I wanted to make. But finally, I think it's important to know that often the best way to get palliative care is to ask your team for palliative care. Many academic centers have palliative care within the academic center. Many of them have palliative care embedded into their oncology clinics or very nearby their oncology clinics. So the services are available to you. I would encourage you to not be afraid to access those services, especially if you feel like I'm not doing as well as I would like to be doing in my day-to-day life. Thank you.